If constipation has lasted 3 days or more, if there's a feeling of something genuinely stuck, not just slow, not just sluggish, but truly stuck, that feeling is not imagined. And it is not a failure of willpower or diet. What is happening inside the rectum at that moment is something most doctors have never taken the time to explain. And the response most people reach for first, the over-the-counter laxatives sold in every pharmacy, can make the situation significantly worse. This video exists because that information gap causes real, preventable harm. In the next 11 minutes, the science of what fecal impaction actually is will be laid out clearly. What triggers it in the aging body, the clinical warning signs, including one that leads almost everyone to do exactly the wrong thing, and a step-by-step, evidence-based protocol for resolving it safely at home. Stay through to the warning signs section. What you learn there may be the most important piece of this. Fecal impaction is not severe constipation. It is a distinct clinical condition, one in which stool has remained in the rectum long enough to lose so much water content that it hardens into a mass the body's own muscular contractions can no longer expel. Research published in clinical gastroenterology literature estimates that fecal impaction accounts for approximately 1 in 3 bowel-related hospital admissions in adults over the age of 65. It is among the most common, and most commonly mismanaged, gastrointestinal conditions in older adults. The mismanagement almost always follows the same pattern. Constipation is recognized, a stimulant laxative is taken, and nothing moves. Because the physiology of impaction makes stimulant laxatives not just ineffective, but potentially harmful. That distinction will be covered in full in the protocol section. The condition builds slowly, over days, sometimes 2 weeks or more. And because its early warning signs overlap with ordinary constipation, it is frequently not recognized until it has escalated to obstruction, to rectal injury, or to a presentation that requires emergency intervention. Understanding what is happening at the biological level is the first step to recognizing it in time. If this is information that should have come from a doctor and never did, subscribe and hit the bell notification. These videos are made to fill exactly that gap. And in the comments right now, type one word, stuck. It helps confirm this content is reaching the people who need it most. To understand fecal impaction, it helps to understand what the colon is designed to do, and what changes in that system after the age of 60. The large intestine's primary role is to absorb water from digested material and propel the remaining solid waste toward the rectum through coordinated muscular contractions. Those contractions, called peristalsis, are controlled by the enteric nervous system, a vast network of over 500 million neurons embedded in the gut wall, sometimes referred to as the body's second brain. As the body ages, that system changes in measurable ways. Research has documented a progressive reduction in the density and responsiveness of enteric neurons after the age of 60. Colonic transit time, the time it takes for material to travel through the large intestine, increases significantly. A 2016 study published in the American Journal of Gastroenterology found that colonic transit time in adults over 65 is on average 30 to 40% longer than in younger adults. At the same time, rectal sensitivity declines. The mechanoreceptors in the rectal wall, the sensors that generate the urge to defecate, become less responsive with age. This means the internal signal that alerts the brain when the rectum is full becomes weaker. In some individuals, it becomes absent entirely. Stool can accumulate in the rectum without generating any noticeable urge to go. Pelvic floor muscle function also decreases with age, reducing the mechanical force available during defecation. Now add the medications that are among the most commonly prescribed to adults over 60. Opioid analgesics, calcium channel blockers, anticholinergic drugs, iron supplements, calcium-based antacids, and certain antidepressants. Every one of these has documented effects on gut motility, slowing the bowel further, often significantly. Layer on top of that the well-established decline in thirst sensation that occurs with aging. Studies consistently show that older adults underestimate their own dehydration. As fluid intake decreases, the colon compensates by extracting more water from stool, making it progressively harder, drier, and more resistant to movement. The result is a physiological cascade: slowed transit, reduced sensation, weakened muscle function, medication-induced motility suppression, and chronic mild dehydration, all converging to create conditions in which stool hardens beyond the body's ability to expel it. That is the biology of fecal impaction. It is not a lifestyle failure. It is a predictable consequence of aging physiology, compounded by factors that are rarely discussed in clinical settings. Understanding the mechanism makes the warning signs easier to interpret, including the one that causes the most dangerous mistake. Sign 1. Absence of bowel movement for 3 or more consecutive days. In clinical practice, 3 days without a complete bowel movement, particularly when accompanied by lower abdominal pressure or fullness, warrants attention. Many adults normalize infrequent defecation, particularly those who have experienced lifelong slow transit. The key distinction is not frequency alone, but frequency combined with the sensations described below. Sign 2. Persistent rectal or lower abdominal pressure that does not resolve. Ordinary constipation produces intermittent discomfort that eases and returns. Fecal impaction produces a constant, low-level pressure in the rectum or lower abdomen, one that does not improve after attempting a bowel movement, does not ease with position changes, and does not resolve with time. This sustained pressure reflects the physical presence of a mass that is not moving. Sign 3. Straining without result, or the passage of only small, fragmented, hard pieces. When the distal portion of an impacted mass breaks away, it may be passed as small, dry, pellet-like fragments. This is frequently misinterpreted as a successful bowel movement. It is not. The sensation of incomplete evacuation that follows, the feeling that more remains, is clinically significant. It should not be dismissed. Sign 4. The one most likely to trigger the wrong response. Paradoxical diarrhea, also called overflow incontinence, is one of the most diagnostically confusing presentations of fecal impaction. When a hard mass is lodged in the rectum, liquid stool from higher in the colon seeps around it and passes involuntarily. This presents clinically as sudden, loose, watery output, indistinguishable to the untrained observer from infectious diarrhea or a gastrointestinal illness. The consequence of misidentifying this as diarrhea is significant. Antidiarrheal medications, particularly loperamide, further suppress bowel motility, worsen the impaction, and can accelerate progression to full obstruction. If watery or loose stool is appearing after several days of constipation, in the presence of persistent rectal pressure and bloating, the correct clinical interpretation is overflow around an impaction, not a separate gastrointestinal event. This presentation requires an entirely different response. Sign 5. Secondary symptoms: nausea, abdominal distension, reduced appetite. As the lower bowel becomes obstructed, the effects propagate proximally. Nausea, visible or palpable abdominal distension, and loss of appetite are documented secondary presentations of fecal impaction. In the presence of pre-existing constipation, these systemic symptoms indicate a degree of obstruction that warrants prompt attention. With the physiology and the warning signs established, here is the evidence-based protocol for managing fecal impaction, beginning with the step that prevents the most common and most harmful mistake. The protocol. A critical safety threshold first. Severe abdominal pain, vomiting, rectal bleeding, or complete absence of any bowel movement or gas for more than 7 days are signs of potential complete obstruction or perforation. These presentations require emergency medical evaluation. Do not attempt home management. For presentations that do not meet that threshold, the following evidence-based stepwise approach is appropriate. Step 1. Discontinue stimulant laxatives. Stimulant laxatives, bisacodyl, senna, and their commercial equivalents, work by stimulating enteric neurons to trigger peristaltic contractions. When stool is impacted and physically cannot move, those contractions produce pain and cramping without therapeutic benefit. Clinical guidelines consistently recommend against stimulant laxatives as first-line treatment for fecal impaction. They are contraindicated in this context. Step 2. Aggressive oral hydration. The immediate priority is rehydration. 6 to 8 glasses of water distributed throughout the day, beginning with a large glass of warm water upon waking, supports gradual softening of the impacted mass. Warm water has a mild prokinetic effect, stimulating the gastrocolic reflex and promoting peristaltic activity. Adequate hydration is also foundational to preventing recurrence. Step 3. Osmotic laxative therapy. Osmotic agents, polyethylene glycol 3350, commercially available as Miralax, and magnesium hydroxide, milk of magnesia, function by drawing water into the intestinal lumen through osmotic pressure, softening the impacted mass from within. A 2010 Cochrane review found polyethylene glycol superior to lactulose for the management of chronic constipation and impaction in older adults. Both agents are available without prescription. Standard dosing should be followed. Escalating the dose prematurely does not accelerate results and may cause discomfort. Step 4. Glycerin suppository. A glycerin suppository, inserted into the rectum with the patient lying on the left side, the position that aligns with the anatomical curve of the sigmoid colon, provides local lubrication and mild osmotic stimulation at the site of impaction. Retaining the suppository for 15 to 20 minutes before attempting defecation allows sufficient time for the glycerin to act on the distal mass. Straining should be avoided. Gentle, relaxed bearing down is appropriate. Step 5. Abdominal massage. Systematic clockwise abdominal massage, following the anatomical path of the ascending, transverse, and descending colon, has been shown in multiple randomized controlled trials to increase colonic transit and reduce constipation severity. A 2018 study in the Journal of Bodywork and Movement Therapies found that 15 minutes of structured abdominal massage per day significantly reduced bowel transit time in older adults. Applied for 5 to 10 minutes using moderate, even pressure below the navel, this technique provides a non-pharmacological adjunct to the steps above. Step 6. Medical review at 48 to 72 hours. If the stepwise protocol above has not produced a bowel movement within 48 to 72 hours, medical evaluation is indicated. Manual disimpaction, digital removal of the impacted mass by a clinician, is a standard, well-tolerated procedure that provides immediate relief. Rectal enemas, administered under clinical supervision, are an alternative first-line approach in some presentations. Neither should be delayed out of reluctance to seek care. Management addresses the immediate episode, prevention addresses the underlying physiology, and for older adults, that distinction is what determines long-term quality of life. Research is clear on the modifiable factors that reduce fecal impaction risk in older adults. Consistent fluid intake, ahead of the thirst signal, which is demonstrably unreliable after 60, is the single most impactful daily habit. 6 to 8 glasses of water daily, beginning with a warm glass each morning, supports both hydration status and the gastrocolic reflex. Ambulatory physical activity has a direct, documented effect on colonic transit time. Studies show that even 15 minutes of walking per day measurably increases gut motility. The colon responds to movement. Prolonged sedentary periods suppress it. Dietary soluble fiber, from oats, flaxseed, legumes, and cooked vegetables, supports stool consistency and transit. The key is balance. Fiber without adequate hydration can worsen constipation. The two work together. And for any new medication, particularly opioids, calcium supplements, iron, or anticholinergics, the appropriate question to ask a prescribing clinician is, what is the expected effect on bowel function, and what preventive measures should accompany this prescription? That question, asked at the point of prescribing, prevents a significant proportion of medication-induced impaction. The physiology of the aging gut is not fixed. It responds to what is given to it. Water, movement, fiber, and informed medication management. These are not passive suggestions. They are evidence-based interventions with measurable effects on bowel function and quality of life. If this filled a gap that a clinical consultation never did, share it with someone who needs it. A parent, a partner, a friend managing the same issue in silence. Subscribe and hit the bell for new videos each week. Coming up next, a condition affecting millions of older adults that is almost universally misattributed, and that responds completely differently once correctly identified. Type "stuck" in the comments right now if this reached you. Every response matters.